Chapters 26 through 30 cover a lot of agents that are commonly used to treat GI ailments. Some of these chapters are relatively extensive and overwhelming in the information that they provide. So this PowerPoint is going to identify sort of the main topics and couple of key medications in each of these GI ailments. GERD, or gastroesophageal reflux disease, is the return of the stomach contents back up into the esophagus. The frequency of this causes the symptoms that are associated with heartburn, and heartburn is manifested as an irritation of the esophagus from those acidic contents of the stomach. Additional complications can occur if we leave GERD untreated long term or if GERD is poorly treated. Many factors can lead to gastroesophageal reflux disease. Obesity and smoking are considered risk factors. Additionally, medications or the side effects of some medications can exacerbate GERD. Luckily, there are both over-the-counter and prescription medications that can treat the symptoms of heartburn before it sort of snowballs into true gastroesophageal reflux disease. And by managing the symptoms, we can hopefully stop the damage and then promote the healing so that we do not get the long-term complications. Now, the saliva helps neutralize the stomach contents. So anything that decreases salivation, and there are some medications like anticholinergic medications, when we use those and we decrease salivation, we can exacerbate GERD. So that's where the idea that the side effect of a medication can contribute to this problem. Additionally, there are medications that themselves lower the tone of the esophageal sphincter, so the area that closes between our duodenum and our upper GI tract. If we make that close with less strength and force and it doesn't seal quite as well, then we can increase the reflux of the stomach contents into the esophagus. And some of the medications that can cause this decreased tone of that sphincter include calcium channel blockers, beta blockers, both of those are used in cardiovascular disease, benzodiazepines, so something that's commonly used in anxiety for a lot of people, and then nitrates, which are not classically used long term. However, frequent use of maybe PRN nitro can lead to a decreased tone in the esophageal sphincter that can sort of perpetuate or last for longer than we want it to. To clear up a quick point I made in the last slide, I said that the lower esophageal sphincter was what closed between our duodenum and our esophagus. Anatomically, that is totally wrong. I meant to say that the lower esophageal sphincter separates our stomach from our esophagus. So when we take medications that lower the tone or the tight closure of that sphincter, that's when we have the reflux of the acidic contents up into our esophagus. So wanted to clarify that point. Moving into this slide then, when we think of heartburn, heartburn is the precursor to GERD really, and we can manage heartburn often at the beginning with antacids. So the relief of these symptoms of the reflux of the acidic contents into our esophagus is managed with antacid use, and it's typically at the onset of symptoms. It's rare for people to take antacids as a consistent preventative measure for the symptoms of heartburn. However, patients will take them if they know they're going to eat an offending meal, but more often than not, they're sort of a retrospective treatment, like, oops, I ate something that is exacerbating my heartburn, and I'm going to manage the symptoms with these agents. Antacids are weak bases that neutralize gastric hydrochloric acid, and when we neutralize gastric hydrochloric acid, we decrease the amount of gastric acid that is available in the stomach, and by doing so, we raise the pH. Most commonly, antacids contain calcium carbonate. That would be in the form of Tums or Rolites. And the reason that calcium carbonate is so widely used is because it's popular, it's effective, it's cost effective, and it's without a whole lot of side effects. There is some risk for drug-drug interactions, but they're pretty mild. Calcium can bind to some other medications and prohibit the absorption of those medications, but it's not something that we commonly see. And generally, if you choose a medication that interacts with calcium, it's one of the top drug-drug interactions, and so it will be clearly noted in drug references. Calcium carbonate containing and really all antacids can be used multiple times a day. However, they can cause rebound acid reflux. And what happens is when we initially decrease the gastric acid in our stomach and raise the pH, our body compensates for that by overproducing gastric acid and trying to lower the pH. We need a low pH in our stomach to help keep organisms and other bacteria at bay so that we don't have a fulminant overtake of those nasty bugs, if you will, in our body. But initially, when we're taking antacids, we're lowering the gastric acid content and raising our pH, and our body doesn't recognize that initially, so it overdoes it. So sometimes we can make heartburn initially worse when we're using antacid agents. As a note, calcium can be constipating, so when we're using or instructing patients to use calcium carbonate containing antacids, we may want to caution them towards constipation as well. As heartburn symptoms progress and are no longer treated adequately with Tums or other antacid agents, we can progress into medications that were classically only available as prescription, but have now made their way into the over-the-counter market as well. The first class of medications is the H2 receptor antagonists, or the histamine blockers. These are available both over-the-counter and prescription, and there's really no considerable differences among the over-the-counter versus the prescription, and then amongst all the agents themselves. The way these medications work is that histamine naturally stimulates acid secretion. So the H2 receptor antagonist drugs then will bind to the histamine 2 receptors on the gastric parietal cells, displacing the histamine from the receptors, thus preventing the stimulation of the acid secretion. This is a reversible inhibition that occurs at a dose-dependent fashion. So the higher the dose of the H2 blocker medication, the more inhibition of this stimulation of acid secretion that occurs. It is stated that as much as 90% inhibition of acid secretion can occur with these agents, making them relatively effective, and near complete inhibition of nocturnal acid secretion can be achieved with these agents. So if we're dosing them once daily, they are best given at bedtime. If patients are using these multiple times a day, they are actually best dosed after meals, because you want to displace the histamine that is coursing through your body as you're digesting foods, so that you don't stimulate excessive acid secretion. This will not inhibit all acid secretion that occurs. It's just inhibiting the acid secretion that occurs via the histamine pathway on the gastric parietal cells. We like to think of proton pump inhibitors then as the next option. If a patient fails an H2 blocker, or their symptoms of heartburn, acid reflux, and GERD persist after using a trial of the H2 blockers, we can move into the PPIs, or the proton pump inhibitors. Again, these are available as prescription, but some of the products are now also available over the counter. There really, again, is no considerable difference among all of these agents, other than perhaps the duration of action, some of them being significantly longer than others. Lansoprazole, which is called Prevacid, esomeprazole, which is Nexium, and omeprazole, which is Prilosec, are all available as over-the-counter preparations. Typically, patients will find that they are quite expensive, so writing a prescription for these products, even though they are available over-the-counter, is sometimes beneficial when we're thinking about cost effectiveness for patients. These will be covered still by the insurance, and the copay is typically less expensive than buying it over-the-counter. The PPIs work by irreversibly inhibiting the acid secretory pump that is embedded within the parietal cell membrane. So again, we're talking about the gastric parietal cells. However, here there's an efflux pump that controls acid secretions, and the PPIs irreversibly bind to those portions of the pump. So by affecting the secretory pump in the cells, we then decrease acid secretion, and by decreasing acid secretion, we're also decreasing the volume of gastric fluid that is available. These act on the cells that are actively secreting acid, so they are best given just prior to a meal. I think one of the clues when you're beginning to eat is your body amps up knowing that it's going to have to digest foods, and it begins to create acid to aid in the digestion process. So by giving these prior to a meal, you have time to limit that acid secretion. That doesn't really affect a person's ability to digest the food they're eating. It just helps with the overly acidic GI environment that can result in patients experiencing heartburn, acid reflux, or GERD. So proton pump inhibitors are considered the most potent available inhibitors of gastric acid secretion. We use them then when the gastric acid secretion causes issues like erosions, ulcers, or things of that nature. when we are trying to treat and heal things like duodenal and gastric ulcers, which are just ulcers occurring in various portions of the GI tract, we consider proton pump inhibitors to be 80 to 100% effective in healing those ulcer lesions. And it typically takes about 4 to 8 weeks in order for those lesions to appropriately heal. This is an important point to make. When we are using proton pump inhibitors to heal specific lesions, we want to use them for the defined period of time. Overutilization of proton pump inhibitors can be problematic. There is some thought out there that perhaps overutilization of proton pump inhibitors can lead to C. difficile infections for patients or some other sort of random side effects, if you will. We also increase the risk for potential drug-drug interactions if we're using them unnecessarily. And if we don't have excessive acid to kind of temper down in a patient, it really doesn't make sense to be giving them an agent if they don't have a specific problem that they're treating. So while patients will use proton pump inhibitors to help control the symptoms that are associated with GERD, long-term use in that setting is probably appropriate. But if we're healing a specific lesion like an ulcer, we want to stick to a specific period of time to ensure that the ulcer is healed. We'll know that the ulcer has healed if the patient can go a period of time then without experiencing symptoms. It's another important point to remember that proton pump inhibitors are part of a regimen that is used to eradicate a bacterial infection that leads to ulcers called H. pylori, and that's going to be covered in a few upcoming slides. As a side note, I've seen this often in practice and it perplexes me. It's unusual for a patient to require both an H2 antagonist and a PPI. If we think that a PPI works on the gastric parietal cells, and it really, in the simplest of terms, inhibits all excessive secretions, all excessive production of acid secretions. It doesn't make a whole lot of sense that if you're inhibiting the acid at the source that you would then need to block histamine, because all histamine does is encourage the secretion of acid from those gastric parietal cells. So it's rare. I'm not going to say I've never seen it. I actually have seen some gastroenterologists prescribe both an H2 antagonist and a PPI, but that is not a typical necessary practice. PPIs are superior to all other anti-secretory therapies for the suppression of acid secretion, the healing of peptic ulcers, and the symptom relief that is seen in patients who present with peptic ulcers. So if you have a patient that's presenting with a peptic ulcer, and I would recommend using something like UpToDate. Our book didn't really go into a whole lot of detail of the patient presentation for a peptic ulcer, but they're going to have epigastric or upper portion stomach pain that will be exacerbated in various states. I believe that ulcers are exacerbated when a patient is not eating, because when you eat, you're amping up your gastric acid, but you're also having food that's being digested by that acid, so that acid is not just free flowing, constantly kind of sloshing over and rubbing over that ulcer. But I would encourage you to read a little bit more about peptic ulcers in another source, just so you're familiar with that. And then when you're in practice, you can recall that if you've identified that in a patient, it would be silly to try anything other than a PPI as a first-line therapy for rapid healing and then the prevention of further complications. This slide just lists the various agents that are available in the category of proton pump inhibitors and then in the category of H2 receptor antagonists. You'll recall that there are not considerable differences among any of these agents. So again, I would ask you to pick one that you would like to become fairly comfortable with, understand its duration of action, make sure you understand its mechanism of action and its common dosing scheme. We most commonly in the inpatient setting will see omeprazole or Prilosec, again because it is widely available both as prescription and over the counter. In terms of H2 receptor antagonists, I probably equally see ranitidine, which is Zantac, and famotidine, which is Pepcid. They both have a duration of action lasting 10 to 12 hours, so again, there's no considerable difference. I will caution you that it is very rare anymore to use cimetidine or Tagamet because it is fraught with quite a few significant drug-drug interactions, particularly some of the more important medications that we use in cardiovascular health or in the treatment of fungal infections, those types of things. So I would caution you to not make cimetidine or Tagamet your go-to H2 receptor antagonist. Of note, in order to make these lists all inclusive, you'll see that there is one agent on the bottom of each list, nizatidine or Axid, which I learned about in pharmacy school, but honestly have not seen in practice in the past 7 years. And then rabeprazole or Asifex was sort of new to the market when I was graduating from pharmacy school and was thought to be like the hot new proton pump inhibitor, but it really has not taken off. And doesn't offer any significant benefit over the other agents that we see. As a note there, the proton pump inhibitors have a duration of action of at least 24 hours, if not a little longer. And you can look into the specifics of that based on the agent that you pick. So a few slides ago we talked about H. pylori. It is an organism that is known to cause GI ulcers, and in order to prevent recurrence of the ulcer we have to eradicate the organism. So if you are treating a patient for an ulcer, and this is why treatment for a defined period of time is so necessary, and you're unable to quote-unquote cure that ulcer for an extended period of time, or even with a short course of a PPI therapy, then you need to consider H. pylori, bacterial organisms causing the ulcers. So multiple treatment regimens do exist, and they all combine a PPI with some antibiotics. There's actually a really good table in the textbook. It's 27-3. I have listed here a first-line regimen that we often see in practice. So a PPI of your choice, again, not a lot of considerable differences. However, omeprazole and pantoprazole seem to pop up more often than others, and this is administered before meals twice daily. It is given in concert with 2 different antibiotics, one of them being clarithromycin, dosed at 500 milligrams twice a day, and amoxicillin, dosed at 1 gram twice a day. So it's fairly simple regimen for patients to remember because they're taking all 3 medications twice daily. This course will run anywhere from 7 to 14 days. And if a patient has a penicillin allergy, then we'll take amoxicillin out of the picture and we'll substitute metronidazole. Brand name of that product is Flagyl in the place of amoxicillin. Once we have finished that 7 to 14 day course for the eradication of H. pylori, it's important to continue the proton pump inhibitor, but only as a once daily administration for an additional 4 to 8 weeks, and then reassessing the cure rate of the ulcer at that time. So this slide will wrap up the portion of the GI agents with respect to heartburn, acid reflux, and gastroesophageal reflux disease. Moving into constipation, it seems like we have complaints of constipation almost as a daily theme in the hospital, be it people being admitted for irregular bowels or while they're admitted, indicating to us that they haven't had a bowel movement in a number of days, if not a week. So constipation means very different things to all of our different patients. Often it is perceived as infrequent or difficult defecation, but the objective definition is 2 or fewer bowel movements per week, which was actually kind of shocking to me when I was reading that in our textbook, because old people in particular seem to be very fixated on the number of bowel movements they have, and they can report almost to the minute if they are or are not regular. The objective definition also includes excessive difficulty and straining at time of defecation. So while patients may note that they're constipated, if they are at least having 2 bowel movements or greater than 2 bowel movements per week, they're not meeting the objective definition. Now that doesn't mean we shouldn't be treating their constipation. Most patients know their bodies fairly well, and if they have a period of significant irregularity from their regular regimen of bowel movements, it's very wise for us to address it and try to get to the root cause. Changes in physical activity or diet are very often the cause of constipation for a lot of folks, and something as simple as increasing dietary fiber can often improve constipation. It doesn't necessarily happen overnight, so because we live in an instant gratification society, it is sometimes difficult for patients to understand that slow and steady wins the race with respect to constipation. Sometimes we have to consider too that medications can be the culprit. So the ones that should pop to the forefront of your mind are narcotic pain medications. That makes sense. Things like codeine, hydrocodone, or morphine. So if we're treating somebody for chronic pain, we should probably recommend that they take some sort of stool softening or fiber containing agent to help them maintain regularity before it becomes an issue of extreme constipation. Antidepressants have been known to cause constipation. Antipsychotics have been known to cause constipation. Anticholinergic agents as well can be drying. So while they classically might not in their package inserts say that they cause constipation, just by the mechanism of which they cause a drying effect that can actually lessen, the ease of movement of the bowel movements. Additionally, calcium and aluminum containing antacids are constipating, and iron. I feel like a lot of people forget about iron. They think of iron as just a supplement. You're most often instructing a patient to purchase it over the counter, but iron is very constipating, particularly in the elderly population. So if you plan on starting a patient on an iron supplement, it would be very wise of you to also at least recommend Docusate or some sort of stool softening agent, maybe in concert with another agent called Miralax, which we're going to get into the details of that in the coming slides. Laxatives are divided into 5 primary categories. Bulk laxatives are non-digestible and non-absorbable. So I think of them as just sitting in the gut or in the colon, in the large intestine, if you will. They absorb water and expand. That increases both the bulk and the moisture content of the stool. If we increase the bulk, we are basically trying to put something thick through a cocktail straw, and in the body that actually stimulates peristalsis, or the downward squeezing motion that moves feces through our bowel. And then by absorbing water, we're actually softening the stool. So we're getting almost a dual effect there. Fiber-containing agents like Fibercon, which is called calcium polycarbophil, and Metamucil, which is psyllium, are 2 products that are fantastic bulk laxatives, if you will. I'm pointing out some of my, well, not necessarily my personal favorites, but the ones that I've seen most often in practice and that I know a lot of patients have used and trusted for some time. So when you're thinking of bulk forming laxatives, you should think of Fibercon and Metamucil. Those are both available over the counter in a variety of dosage forms: tablets, capsules, wafers. I think there's like a Metamucil cookie or cracker out there. Metamucil is also the commercial of the orange jug, and the people are dancing about mixing it in their water and drinking it with no gritty taste, and life is groovy for those folks. Stool softeners are something that we think of for a lot of patients. They soften the stool by lowering the surface tension by mixing aqueous and fatty substances in our waste matter. This allows for the fecal mass to be infiltrated then by the intestinal fluid. So really the only thing we're doing here is softening it. So for some folks, all they do need is a softer bowel movement product in order to get it through the system. But stool softeners alone cannot usually cure, constipation for a lot of folks. So the stool softener that we most often see is Docusate Sodium or Colace. Osmotic laxatives then are those that are non-absorbable sugars. So because they're non-absorbable sugars, bacteria metabolize these into various acids, which then increases the movement of water into the bowels. So again, you are increasing the bulk of the bowel and you're sort of softening it, and that will increase peristalsis, or again, that downward movement of that waste matter through our bowel system. Glycerin suppositories are obviously only used in a rectal route, but here's where Miralax comes in. That's polyethylene glycol, or PEG is the other name for it. So when we have patients that are not responding to stool softeners, just the softening of the stool in the hospital setting, we will often add an osmotic laxative like Miralax. Now this is a powder formulation, but it is odorless, tasteless, and colorless, and it can be mixed into a variety of soft foods and beverages. So that's a wonderful one to keep in your arsenal of agents to treat constipation. Stimulants then are actually irritant laxatives that increase peristalsis via several mechanisms. They have a direct act on the intestinal mucosa, the nerve plexus that's contained in there, and then they activate the walls of the intestine, actually causing the muscles to contract. So we can use stimulant laxatives both as oral preparations and as suppository preparations. So when we think of suppository stimulants, Dulcolax or Bisacoidal comes to mind, and that stimulates the sensory nerves in the intestinal mucosa. So it triggers them to activate the peristalsis movement. Senna then is an oral tablet whose action is specific to the colon. It alters the permeability of the colon cell walls, resulting in increased fluid accumulation in the colon. And when we have an increased fluid accumulation, we're getting a little bit of a softening effect, but we're also getting an effect to stimulate the peristaltic movement of the colon. Enemas work primarily by inducing evacuation as a response to distending the colonic wall, and then via lavage. Lavage is just a general term that refers to a cleansing or a rinsing. So it creates a barrier between the feces and the colon wall, preventing the reabsorption of the fecal fluid, softening the stool, and allowing it to relatively quickly and in a rather violent fashion evacuate from the colon itself. So oil retention mineral enemas work by lubricating the rectum and the colon, so it allows for easier passage of that fecal movement mass. Soap suds enemas provide an irritant action, so your body wants to try to expel it. And then phosphosoda is the generic name for fleets. That's something that those of you that have worked in the hospital setting might be familiar with, are actually saline laxatives, which draw water into the colon. And by drawing water into the colon, you create a very explosive eruptive effect in about 1 to 5 minutes. So enema should really be reserved for those situations where we cannot get movement of that fecal matter through any other sort of source, or immediate removal of that matter is necessary. We should not encourage patients to be using enemas on a regular basis at home. Rather, we should look for the root cause of the constipation and treat that as a first line. The drugs of choice then in the treatment of constipation are listed in this table. We're going to address both short-term and long-term constipation, and then take a quick look at first, second, and third line options. Short-term constipation can be defined as something that's not chronic. It might be related to the maybe starting of a new medication, of a change in a chronic disease state that we don't expect that change to have long-term effects or long-term ramifications, and it's mild. And in those patients, we want to use a bulk-forming laxative. So that's the Fibercon or the Metamucil. Now, if patients have long-term constipation as well, the bulk-forming laxatives are actually our best go-to option because, again, they act rather naturally in that they're really just pulling the fluid in, softening the stool, bulking up the stool so that you are encouraged, your body is encouraged to have that peristaltic movement to move the fecal matter through. Now, of note, when we're thinking about specific patient populations, patients that are likely to benefit from bulk-forming laxatives include postpartum, so if you've just delivered a baby, elderly folks, and then debilitated patients. Second line for short-term constipation, or those patients that are presenting, they've skipped over mild and they're right at severe, an enema is appropriate for those folks. We know that they're not going to have, that it's not chronic long-term constipation, so we're not just putting a band-aid, if you will, on the problem by helping them evacuate their bowels. What we're doing with the enema is clearing that occlusion or that fecal matter mass so that they can hopefully get back to regular bowel routine. Long-term, a second line agent, either in addition to a bulk forming laxative, or if patients have failed a bulk forming laxative, you can move to an osmotic laxative, and that kind of my go-to of choice is Miralax or PEG, the polyethylene glycol. Lastly, third line in both short-term and long-term treatment of constipation should be stimulants. So our go-to, although it's kind of a knee-jerk reaction, might be Docusate plus Senna, the softener and the stimulant. If we can encourage the body to stimulate itself for bowel movements, that's preferable than having a pharmacologically induced stimulation of the bowel tract. So instead of acting on the nerve plexus directly or affecting the colon wall, we are encouraging water movement in and out of the colon, bulking of the fluids with all of these other bulking of the stools, excuse me, with all of the agents we had talked about previously. Stool softeners are not on this list, but stool softeners are important when we're trying to reduce straining at the time of stooling. And so there is a patient population that benefits from the action of stool softeners, and those would be patients with a hernia, patients that have had cardiovascular disease or recent surgery in which straining is not advised, and that can include postpartum patients or patients that have had rectal surgery. So sometimes it's probably more common not to think of stool softeners as a first-line treatment, but as an additive to some of these other agents that we're trying. Switching gears, then we're going to swing to the opposite balance of what would I say, bowel irregularity, and we're going to talk about diarrhea. So like constipation, diarrhea is a symptom, and the primary treatment for diarrhea should really be focused at the underlying cause. When we're talking about the diagnosis or the definition of diarrhea, we need to classify it by frequency, not consistency. So a lot of times people will say, oh geez, I had diarrhea because their stool was a softer consistency than what it typically is. But the true medical definition of diarrhea is the 2 or 3 bowel movements per day that are liquid, not just soft. Again, though, like constipation, bowel irregularity is very uncomfortable for a lot of folks. So we want to try to help them manage it in the short term so that it doesn't become a long-term problem, and so that they perhaps don't stop taking medications or stop eating and become dehydrated, stop drinking fluids and becoming dehydrated, all because the need to defecate so often is very uncomfortable and sometimes incredibly inconvenient. Most episodes of acute diarrhea are benign and self-limiting. So once your body kind of sorts out what is the trigger for this issue and clears it out of the system, it'll resolve. Antidiarrheal agents can be used for no longer than 48 hours, and we use them to manage the abdominal discomfort and the frequent bathroom trips that are associated with diarrhea. Now, under the direction of a gastroenterologist or perhaps a nurse practitioner that has a specific specialty in GI-related problems, we will see, obviously, antidiarrheal agents being used longer than 48 hours, but if a patient's treating themselves over the counter, or if you're giving them a short course to try to get them over the hump of an issue of acute diarrhea, we really don't want them to use them for longer than 48 hours. Anytime diarrhea persists for longer than 2 weeks or changes in appearance, like it becomes bloody or white and chalky in color, a patient should be referred to more specialized care. So when it kind of gets outside of your scope is when it's not, classic or routine diarrhea. Large volume diarrhea, so copious amounts that are evacuated multiple times a day, is caused by excessive quantities of water or secretions into the intestine. And that occurs most commonly because bacterial toxins will produce hormones that stimulate the secretions in the gut. So here we're basically just loading and overpowering the gut with watery secretions, and that is making the stool significantly softer and in a more liquid state than normal. Small volume diarrhea then is caused by excessive intestinal motility. So we're moving things through the system a lot faster than we wanted to. That is usually caused by an inflammatory condition that affects the gut mucosa. So I think it's interesting to know that diarrhea comes from both things moving through too quickly and things being diluted to an excessive amount prior to moving through our colon or our bowel tract. So we have 3 classes of antidiarrheal agents, and we have the opioid agents, the anti-secretory agents, and least commonly the adsorbent agents. Opioid antidiarrheal agents act on the smooth muscle of the intestinal tract to slow GI motility and propulsion. That makes sense because earlier when we were talking about constipation, we talked about how narcotic opioids cause constipation. Well, they do so by acting on the smooth muscle. So by slowing the GI transit time, we're allowing for more fluid to be absorbed from the stool. That decreases our fecal volume, and it decreases the fluid and electrolyte loss as well, so we're not running into the issues of dehydration. And even though we classify the medication that I'm going to name next as an opioid to treat diarrhea, it really has little to no analgesic activity. So you're not getting the same sort of effect as you are from an opioid narcotic like codeine or morphine or hydrocodone. So this opioid antidiarrheal agent is referred to as Lomotil. It's a combination of diphenoxylate and atropine. Now, because in theory, an opioid antidiarrheal could be habit-forming, atropine is added to discourage the abuse or overdose of this agent. Imodium is also considered an opioid antidiarrheal agent. Its generic name is loperamide, but it is not habit-forming. Anti-secretory antidiarrheal agents then are combo products that offer anti-secretory properties coming from the salicylate part of the product and, proposed antimicrobial effects coming from the bismuth component of the product. So Pepto-Bismol is an anti-secretory agent. Adsorbents then are not something that I see commonly utilized in the hospital setting, and I don't have a lot of outpatient experience with diarrhea, to be honest with you. However, adsorbents can be used in infectious diarrhea because their mechanism of action is that they bind to the bacteria and the toxins in the GI tract, sort of almost being the chaperone to shuttle them out of the GI tract. An example of an adsorbent antidiarrheal agent then is kaopectate or adapulgite. I believe I pronounced that correctly, although don't take my word on it. So when do you treat diarrhea? Diarrhea that is bacterial or toxin in origin should generally not be treated with antidiarrheals. And that's because if the patient's or the body is trying to rid itself of those toxins. And so if we stop the elimination of those toxins, we can actually exacerbate the diarrhea and lead to additional complications. If the patients, however, find that the diarrhea is significantly inconvenient or perhaps painful, then antidiarrheals can be used in the short term and sporadically to provide comfort. Once an underlying cause of chronic diarrhea is identified and treated, then antidiarrheals can be used in that population on an as-needed basis to control symptoms and prevent dehydration. Fiber products are unique because they can be used to treat both constipation and diarrhea. Fiber products are safe to use every day, and they help control the symptoms of both chronic constipation and chronic diarrhea. I'm not exactly sure how it knows what your body needs, but it does. Opioid antidiarrheals are also best reserved for chronic diarrhea patients because they'll be used on an as-needed basis, not something that's going to be used, with every bowel movement or multiple times a day for a number of days in a row. So if you think it's bacterial or a toxin, don't treat it. Let the body rid itself of this acute offending organism. Within 48 hours, the patient should have significant turnaround, and very short-term or sporadic use of antidiarrheals in those cases might be helpful just to manage the symptoms and the inconvenience. Although Table 29.4 in the textbook on page 335 has a table for the dosing and administration of antidiarrheal agents, I'm going to point out some of the key things here. Lomotil, again, diphenoxylate and atropine, is given as 5 milligrams 4 times daily. Again, we're telling patients probably not to take this around the clock, so up to 4 times daily as needed for diarrhea symptoms. Each tablet of Lomotil contains 2.5 milligrams of the diphenoxylate, so each dose is actually going to be 2 tablets. I think that's important to keep in mind when you're dispensing a quantity of tablets for a patient. You don't want to under-dispense so that they only have a couple of doses worth, but you also don't want to send them home with 180 tablets, which is going to be a bit excessive. Imodium or loperamide is available over the counter. The dosing scheme for loperamide is to take 4 milligrams initially, and each tablet or caplet of loperamide is 2 milligrams. So initially they're going to take 2 caplets of Imodium, and then for each loose stool thereafter, they're going to take just 1 tablet or caplet, so only 2 milligrams. And patients can use up to 16 milligrams a day, which equates to 8 tablets per day. Pepto-Bismol then is typically dosed as 2 tablets. I looked at a couple of different bottles that I had access to, and I didn't see anything significantly different from that. And those can be taken every 30 to 60 minutes as needed, up to 8 doses, which is actually 16 tablets. So that's the flip-flop from Imodium in a 24-hour period. As a side note, it's important to caution patients, if you're going to recommend that they take Pepto-Bismol, caution them that it can turn their tongue a dark color or it can darken their stool. So that'll sometimes throw people off and they get a little freaked out by that. So that counseling point, if made by you and then hopefully reiterated by the pharmacist if the patient pays for their medications at the drug counter, will help them avoid any surprises when they're taking Pepto-Bismol. On the last slide, I said that table 29.4 for the dosing and administration of antidiarrheal agents was on page 335. It's 355. So wanted to clear that up so people were not looking at a random page in the book that has nothing to do with diarrheal agents. Moving into the last section then for this week's topic is nausea and vomiting. Agents that are used to treat nausea, vomiting, and even vertigo are chosen because of their activity on the central nervous system. In all cases of nausea and vomiting or vertigo, the underlying cause again should be established because typically these symptoms are manifestations of pathophysiologic problems that are going to require further workup and a little bit more attention to detail so that you're not covering up a diagnosis or misdiagnosing something. If you're treating nausea and vomiting without a known cause, it can lead to delays in diagnosis and perhaps progression of diseases that might be otherwise relatively benign if we catch them in the beginning phases. So always look, constipation, diarrhea, nausea, and vomiting, always look for that potential underlying cause, be it a disease state, be it a change in physical activity, diet, other activities of daily life habits, or medications. All of those things are important to consider because most often those three complaints are symptoms of a different issue. So how is nausea and vomiting triggered? I think it's important for us to understand this because then we're going to try to better correlate how the medications that are available to treat this complaint work. So the communication of drugs and hormones with the vomiting center or the VC in the medulla is sort of the central warehouse for the message that gets to the brain that tells you, I feel like garbage, I think I'm going to vomit. And various drugs can make that message be expressed there, and other hormones that are coursing through our body can make that message be expressed there. Abdominal peristalsis then, or forward movement of gastric contents, will sometimes result from a blockage or slowed nerve innervation. So nausea and vomiting is triggered by that communication, by the abnormal peristalsis or forward movement of the gastric contents. Vertigo then, which can lead to nausea and vomiting, is caused by an inflammation of the semicircular canals of the inner ear, and that throws off that communication balance. Motion sickness is caused by a repetitive motion, be it angular, linear, or vertical. And then table 30/2 in our textbook has a really nice breakdown of the different triggers of nausea and vomiting and which receptors are involved. Taking a peek at that can help us aid in product selection based on the patient's presentation. Here is a Jeopardy fact. In retroperistalsis, which is reverse peristalsis, so peristalsis is moving things down and through the GI tract, so retroperistalsis is the movement of contents up our GI tract, which is called the act of vomiting. That actually originates in our small intestine. I just found that sort of interesting, and if any of you make it to Jeopardy someday, I'd like you to win. So remember that fact, and I think you'll probably be guaranteed a large prize. At our house, we call vomiting the reversal of fortune. So that's a good way to make a rather unpleasant act something that's a little bit more comical. Breaking down the medications, the classes of medications used as antiemetics, the first one we're going to talk about is antidopaminergic. These are some of the oldest drugs that are used for nausea and vomiting. They've been around for a long time. We have a lot of data with them and experience with them. They are, however, not as effective as other agents, but they're a good start for somebody that's complaining of mild to moderate nausea and vomiting. Oftentimes, we will see these agents combined with antiemetics from other classes, and that's particularly true when we're treating like chemotherapy-induced nausea and vomiting. If we can attack that message from a couple of different pathways, we're going to be more successful in limiting the actual sensation of nausea and the actual act of vomiting. So, antidopaminergic agents are promethazine, brand name Phenergan, prochlorperazine, brand name Compazine, and metoclopramide, brand name Reglan. I'm going to suss metoclopramide out for a minute and talk a little bit more specifically about that one. It has additional mechanisms of action rather than just affecting the dopamine in the body. It will stimulate the upper GI tract, and it appears to increase the GI tract tissue responsiveness to acetylcholine, which increases the tone of the GI tract and the amplitude of gastric contractions, So it has prokinetic properties in that it increases peristalsis, and as an antiemetic, it antagonizes both the central and the peripheral dopamine receptors. So we actually see metoclopramide utilized quite a bit for nausea nausea and vomiting. In the hospital setting, it's part of our post-op nausea and vomiting regimen. We see it in patients that are experiencing slowed GI transit. So those would be our diabetic patients who are experiencing some diabetic neuropathy that's affecting their GI nerve innervations. And we will also sometimes see this as an adjunctive treatment for patients that are having chemotherapy-induced nausea and vomiting issues. Anticholinergic agents that are used as antiemetics have antiemetic, anticholinergic, and antihistaminic properties. So the exact mechanism of action of these medications in treating or preventing nausea and vomiting is not entirely known, but it's thought that these drugs have suppressant action on hyperstimulated labyrinthine function, so the sensing capabilities of the inner ear. So we will often see anticholinergic agents deployed in cases of motion sickness or vertigo. That's where they're most effective. So meclizine, which is sold under the brand names of Antivert or Bonine, and dimenhydrinate, which is sold under the brand name of Dramamine, are common anticholinergics that we can use for complaints of motion sickness or vertigo. Antihistaminic actions also contribute to the potential for drowsiness when we're using these agents, so we have to remember that when we're prescribing these to various patient populations. Caution the use maybe in cross-country truck drivers who get some motion sickness, people that are going to be traveling that do not want to fall asleep, those types of things. Another agent that is an anticholinergic antiemetic is scopolamine, or a transderm scope patch. So this is a topical patch that's actually applied behind the ear, and it helps mitigate the motion sickness symptom that is accompanied, not associated with, but is accompanied by nausea and vomiting. So this inhibits the vestibular input to the central nervous system and inhibits the vomiting reflex. I can remember as a child, every time we went on vacation, my mom would wear a scopolamine patch. We don't see them utilized in the outpatient setting very often anymore, and I have to be honest with you, I'm not entirely sure why. It's probably safer to use something like meclizine or dimenhydrinate, which is Dramamine, because we know the absorption of that oral tablet better than perhaps the topical absorption of scopolamine. Traditionally, patients would also cut those in half if a full patch was too much or too potent. So that was something that classically was used, but is sort of falling out of favor in terms of its antiemetic properties. As a side note, I don't know that many of you will come across this in your nurse practitioner practice, but we do use scopolamine patches in the end of life or palliative care. We use it as an anti-secretory agent. So we will apply patches for patients that, as they're starting to near the end of life, have excessive oral secretions, and using scopolamine, again, because it's an anticholinergic and it has drying effects, we can help limit the oral secretions that occur for those patients. The serotonin 5-HT3 receptor antagonists are commonly used in the pre-treatment regimens for chemotherapy treatment and are often used to help control post-op nausea and vomiting. So the way these agents work is that they antagonize the receptors for serotonin that are released by cells in the GI tract. Basically, they limit the message of I need to vomit from ever getting to the central processing center. The most commonly used 5-HT3 receptor antagonist is ondansetron or Zofran. So we see that almost in every chemotherapy-related anti-nausea regimen, and it is used now rather widely in both inpatient settings. It's one of our go-tos for our post-op nausea and vomiting that originates because of the sedative medications we use in those patients, and we're actually seeing it a lot more often in the community setting as well. So ondansetron or Zofran is one that's worth you knowing some detail about because it's something that you will probably readily prescribe in a variety of settings where the complaint is nausea or vomiting. So some dosing tips for the various antiemetic agents. Prochlorperazine is dosed as 5 to 10 milligrams taken orally every 6 to 8 hours as needed, and the maximum daily dose for this agent is 40 milligrams. Meclizine is dosed as 12.5 to 25 milligrams by mouth every 6 to 8 hours as needed. And then dimenhydrinate, which is sold over the counter as Dramamine, is 50 to 100 milligrams by mouth every 4 to 6 hours as needed, up to a maximum daily dose of 400 milligrams. Do I think you need to memorize these doses doses? Absolutely not, but I think it's helpful to at least recognize what those doses are so that if you see a dose or if you're trying to look up a dose and you're in a reference that might not be entirely reputable, you can try to recall what is a ballpark of normal. Ondansetron then, which is Zofran, is dosed as 8 to 24 milligrams by mouth. That's the textbook definition. More commonly, we see it written as 4 to 8 milligrams by mouth every 8 to 12 hours. And there's no maximum daily dose noted. And that's because it's used in such a wide variety of nausea and vomiting complaints. We probably tend to see higher doses or more frequent dosing when we're using it in a chemotherapy related regimen. Ondansetron is one that we talked about really briefly in our very first lecture when we were talking about sublingual preparation. So ondansetron comes as an orally disintegrating tablet, and that allows for the ease of administration in cases of severe nausea, where even something as small as a sip of water to get that tablet down the hatch would trigger a nauseous response and possibly vomiting. So the orally disintegrating tablet dissolves incredibly rapidly on the tongue and then is completely absorbed via the mouth mucosa. So in conclusion of this week's lesson, I think in order to make sure that you have a handle on the topics, it would be worthwhile for each of you to create a document for yourself that lists an agent or two from each class that was covered in this PowerPoint. That'll help you begin to design or create your favorites that you can utilize in clinical practice. So when you're a new practitioner, and I utilized this theory when I was a new pharmacist, I had an external brain. I wrote down the things that I wanted to be most comfortable with, and so I'm suggesting that for you, you pick a couple of agents in each of the classes of medications that we talked about today. You will then begin to learn things outside of those favorites, but the favorites are a great place to start. So this is not an assignment. I don't need you to turn anything in. It's just me kind of offering some food for thought that if you organize what was covered this week, it seems less overwhelming when you are maybe trying to address these problems in your clinical practice, studying for a midterm or quiz type setting, and then starting to build your knowledge that you're going to utilize as first line when you're treating your patients, looking up some of those weird kind of off the cuff things that I don't think are necessary to memorize because we've got enough going on in our brains these days. But if you start somewhere, then at least you have a couple of things in your bag to pull from rather than having just a very vague idea of kind of what we talked about today. So what do I think a document like this would include? I think you could probably put the indication for the drug that's going to help you identify, was it an anti-diarrheal agent, an agent to treat constipation, were we talking nausea and vomiting, were we talking GERD, the mechanism of action. And I'm not entirely impressed with this book's setup of describing the mechanism of action of medication, so it might be easier for you to find a more succinct description of a mechanism of action in a source other than the textbook. A common dosing scheme, so either what I've listed here in the slides or if there's more detail in the textbook or another reference that you'd like to include. And then significant adverse reactions, again, that's better found in a specific drug reference since I didn't find the side effect tables to be very helpful in this textbook. My issue with side effects is that when you're using a non-pharmacy reference, they're just too specific. They include practically every side effect under the sun. They don't really give you an idea of kind of what's central to each of the agents. Now, I'll tell you, going forward in lectures, if there are significant adverse reactions, I'll point that out to you. There are not a whole lot for the agents that we've talked about in today's lesson. So that part of your document for this week might be a little sparse, but that's all right. When there are things that I think are worth knowing, I will point those out to you. So thanks very much.